episode of Banner Health's Making the Round podcast, we'll be discussing foot and ankle reconstruction, mastering joint sparing versus joint sacrificing strategies, and arthroplasty innovations. To learn more about these topics and other orthopedic-related offerings at Banner Health, please visit bannerhealth.com/orthopedics. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. With me today is Dr. Damien Richardson, orthopedic foot and ankle surgeon with Banner University Medicine and Banner Sports Medicine Scottsdale, and assistant professor at the University of Arizona College of Medicine Phoenix, Department of Orthopedics. Welcome to Making the Rounds, Dr. Richardson.
Hey, Bridget, it's good to be back.
Good to have you back.
Thanks for having me.
Absolutely. So for our listeners who did not catch our first one, please go back and listen to Dr. Richardson. But can you share with us and share with our audience what inspired you to go into foot and ankle orthopedics? Tell us a little bit about your journey and a little bit about you.
Sure. So I'm a orthopedic surgeon here at Banner Health. I have a background in sports. Some of you may know, played professional football for a few years. And then when I retired, I kind of picked back up. I was a bioengineering major at ASU and then pre-med, and then fell back into medicine right when I got done playing medical school at UCSF. And I did my residency here at University of Arizona. Dr. McKee and company were my attendings, and went private practice, and now I'm back in academics and happy to be here.
So, Dr. Richardson, today we are discussing foot and ankle reconstruction and joint sparing versus joint sacrificing procedures. And I'd like to start with what I feel in this conversation as an obvious question. What is foot and ankle reconstruction?
Right.
And why is it so important to really distinguish between joint sparing and joint sacrificing?
As orthopedic surgeons, we're doing typically one of three things, sometimes a combination. That's either repairing something, like putting the ends of something that's torn back together, fixing a fracture, removing something from a surgical perspective that's maybe bothering a patient, a lump or bump, or maybe a small torn tendon or meniscus in the knee, or reconstructing. And reconstruction is really advanced form of repair, where you're rebuilding and restructuring damaged or deformed particular anatomy. And with reconstruction, it's obviously more complex, and the tools we use and the techniques might include tendon transfer, osteotomies to reshape the bone, fusion surgery, or even replacement of a joint. And so when we start going down our treatment algorithm for reconstruction, from an ankle perspective, if we kind of trace our history of this idea of joint sacrificing and joint sparing techniques back to one of the pioneers of our profession, Dr. Sigvard Hansen, who in around the turn of the century, which was not that long ago, I was actually alive then, in the year 2000, came up with a book called the Functional Reconstruction of the Foot and Ankle. And in it, he described in the foot here certain joints that are essential, that we need for motion, like the ankle, certain joints that are non-essential, that we need for stability, like across the midfoot, and the certain joints that can kind of go in between. And so when we think about a joint sparing or a joint sacrificing approach to reconstruction, we're thinking about, okay, if I'm going to need to save a joint that is essential, that I need for mobility, I want to do things reconstructively around it, whether it be osteotomy or tendon transfer, to save it as much as possible. If the joint is one that is what we would consider unnecessary, there's little movement in it, then I could sacrifice it. I could either fuse it and sometimes even replace it. And so, even replacement is a form of reconstruction. And we can talk about that more later when we talk about total ankle replacement. But you're still sacrificing the joint in essence, because you are removing the entire joint, if that makes sense, and replacing it with parts. So joint sparing means we're doing things from a reconstructive perspective to keep the joint, improve the function, improve the patient's pain, but then, we're not taking the essence, the cartilage away from the joint. We're improving the anatomy and the alignment. And that's what's beautiful about foot and ankle surgery or foot and ankle reconstruction is that there are there are 19 tendons, 26 bones, 33 joints, over 100 ligaments in this one little area right here. So, and that's what got me asking before, what got me excited about foot and ankle. And I think most of us who go into foot and ankle, we enjoy that challenge and the reconstructive part of it. And it because it is different. It's different than total knee or total hip. And I'm not trying to talk down on my arthroplasty buddies,
No,
but
coach.
there's three joints to the knee, right? Or two joints to the hip, right? And so but here in the foot, right, there's an interplay amongst all these joints. So when we think about the reconstructive part of what I do, it's all about maintaining that balance. What am I doing to keep the kinematics and the mechanics of the foot um, essentially consistent throughout the procedure.
So when you're talking about all of these different procedures between the amount of bones and the amount of ligaments, what are some of the most common foot and ankle reconstructive procedures that you implement in your practice?
Sure. So, I mean, there are lots, right? And so, come back to the foot. We think about the foot in three different sections: forefoot from the metatarsals down, midfoot between the metatarsals and the talus here, and the calcaneus, the heel bone, and then the hindfoot. And so, within these three parts, we see the majority of the reconstructive procedures. In the forefoot, probably the most common, most popular are bunion corrections, hallux valgus surgery. Within the midfoot, around the navicular and the talus, we see a lot of pathology around flat foot and the arch, which is what I was trying to demonstrate here, right? And this is, flat foot deformity, flat foot reconstruction is one of my personal favorites, just like I would say bunion correction is. But a lot of critical thinking goes around, addressing the patient's chief complaint and helping them. And then in the hindfoot, I would say the main reconstructive procedure we're doing nowadays is total ankle replacement. It used to be ankle fusion,
Yeah.
which was the gold standard.
Yeah.
But now total ankle replacement has kind of taken the lead in terms of patient satisfaction and outcome.
My grandmother, I remember growing up as a kid, she had a fused ankle. So she always had to have, just that perfect height in all of her heels and little wedges. She could never walk around flat-footed, and I never understood, like, why can't you just put flip-flops on? Why
Well,
can't you
I mean,
just walk around?
don't get me wrong.
Yeah.
I mean, a great ankle fusion is a great pain reliever, and still, by some measure, the gold standard. And I think that I have a lot of tools in my toolbox to do both fusion arthroscopically, the minimally invasive procedures, as well as do a more formal open ankle replacement. And so I still think that that's an important tool to have and treatment for our patients. But nowadays, and I'm excited to talk about it, the total ankle replacements in our fourth generation, and we're having great outcomes and success with this procedure.
I love that you're sharing that you have all of these tools in your toolbox. So when you have these patients, how do you assess which patients are candidates for reconstructive surgery?
I listen to the patient. I mean, it's a simple, doctor 101 here, right? We've all been in medical school, and I listen to the patient and hear what their goals are, and try and frame a treatment around where they're at, where they want to be, and also what can they endure during the treatment process, because reconstruction is a it's a journey.
Um, how do you address the functional and aesthetic outcomes of foot deformity corrections with your patients?
Right. Uh, we have a saying in our family, smart first, pretty second. Also, I tell my daughters, okay, I feel the same way about my reconstruction, okay? Functional first,
Right.
pretty second. And when I'm doing a good job correcting the deformity, I would say my patients are very happy with the aesthetic part. And that goes for bunions as well.
And you're saying joint sparing versus joint sacrificing.
Certainly.
What does that mean to me? Can you give me either a visual
Yeah.
with your product or
So sometimes the deformity has progressed too far, and the degeneration and arthritic change has advanced. And at that point, I can correct the bunion, where the toe is coming over this way, but to correct it, I have to fuse it. There's too much the contractures, there's too much stiffness, there's no mobility. So why would I want to save the joint when this is uh, not an essential, not an unnecessary, but the first MTP joint is a non-essential joint, which means you can live with it fused. It actually, great toe fusion is a good option for some of my patients who um, have arthritis of their great toe and they have bad bunion pain. And so I sacrifice the joint to take care of their pain, to improve their function. And yes, they've lost mobility, but they made up for that with the other factors. And so these are some of the part of the algorithm that I go down with our patients when we're talking about joint sparing versus joint sacrificing.
I'd like to pivot a little bit, Dr. Richardson, and talk more about the ankle arthroplasty and the joint
Sure.
replacement that you bring to this practice. Can you tell us a little bit more about this treatment, as this has been a growing treatment? Can you describe this treatment for us? 20, 30 years ago, all I knew is something happened to your ankle, you had to fuse it.
Right, right. Big picture, ankle arthroplasty is restructuring the ankle by taking the joint out that is completely degenerative and painful and replacing it with metal and plastic components. And the metal components sit on the talus bone here, as well as on the top portion of the tibia, we call the plafond, and the plastic in between that create a smooth surface. Now, we are in our, I believe, fourth generation of total ankle arthroplasty, and we've come so far from the first generation, which was in the 70s, and they went pretty much every decade in terms of the advancement uh, in the techniques and the implants. And we have borrowed some from our hip and knee colleagues in terms of material science and some of the instrumentation used to put a total ankle in effectively. But nowadays, we're seeing great survival rates at 10, 15, 20 years. And that's what it's all about.
So, when we look at patient symptoms, patient conditions, what are some of those factors that you consider when determining, okay, this patient has gone through all of these steps and is a candidate for total ankle arthroplasty?
The most important thing is pain. And, our patient-reported outcome measures nowadays are really, honing in on the fact that the more pain that you have preoperatively, the better your gains are the better your outcomes and your satisfaction it will be from a procedure such as this, right? And so, my patients who are, playing pickleball and they have a little bit of, or a lot of ankle arthritis, and some deformity, but hey, doc, I'm out there playing pickleball every day, and they come in and their ankle's a little swollen, but they're able to still do their activities of daily living and participate with sport. They're not. I'm not so concerned about what the X-rays look like, and I wait and I watch and we listen and I support them with bracing or with sometimes with injections. The major complication and risk for failure from an ankle arthroplasty is loosening of the parts. Call that aseptic loosening. And that's because the force that comes through your ankle is tremendous. It's different than the forces that are coming through the knee. And that's because there's a smaller area of contact, surface area. Um, and so having said all that, and the fact that in your gait you have single limb stance, and some patients are trying to go back to playing tennis, you have 5 to 6 times your body weight coming through a small little area, and so you have to have implants that are put in very accurately, that are centered and are at that take into account the kinematics and the shape of the ankle, which is extremely complex, that we're solving. We're more successful at these days.
So, for our physician listeners, what advice would you give when considering a referral for foot and ankle reconstructive procedures?
Certainly. So I would love to see patients early, and just to remember that just because you send a patient to orthopedic surgeon doesn't mean we're signing them up for surgery right away. And I have a big non-operative toolkit, and I like to get to know my patients. I like to get to that's my only way is to get to know them during that time period. And then obviously if things need to happen faster, we're prepared to do that. But the sooner the better, because the deformity, the complications from immobilization, the wrong type of physical therapy could set us back a little bit, and take some of the things off the table. So yeah, please, I'm happy to see your patients as soon as possible.
Well, thank you, Dr. Richardson. We really appreciate you sharing your insights and expertise with us today. And we just can't thank you enough for being a guest 2 times around on Making the Rounds.
You can tell I'm enjoying myself. So looking forward to the next time. Thank you.
Absolutely. Thank you for joining us in this conversation through orthopedic foot and ankle reconstruction surgery. If you found this conversation as fascinating as we did, please subscribe to our podcast for more discussions on important medical topics. To learn more about Dr. Richardson and the orthopedic specialty services available at Banner Health, please visit bannerhealth.com/orthopedics. Thank you for listening, and we'll see you next time on Making the Rounds.